Good evening, everybody. Thank you so much for joining us on this cold Melbourne rainy winter night, nearly spring. We are so excited to be here this evening for our second in our webinar series, No Endo, Getting an Endometriosis Diagnosis. Before going any further, we first need to acknowledge the country that we're on. So Epworth Healthcare acknowledges the peoples of the Kulin Nations, the traditional custodians of the land upon which we work and care for our patients. We honour the unique and continued spiritual connection that Aboriginal, Australian and Torres Strait Islander peoples have to land, waters and culture. Right, we have some amazing guests with us this evening. Next to me tonight, we've got Dr. Laura Chapman. Laura gained extensive hospital experience prior to completing GP specialist training in 2008. She undertook a certificate of women's health in 2017, including a clinical component in gynaecology, which led to a growing interest in pelvic health. Laura practices holistically and aims to be approachable to patients of all ages and backgrounds. After we hear from Laura, we're going to hear from Dr. Alison Bryant-Smith. So Alison Bryant-Smith is a consultant obstetrician / gynaecologist at Epworth, Richmond. She specialises in advanced laparoscopic and hysteroscopic surgery. Alison completed her Aegis Fellowship in Sydney, which you'll hear more about. And during this 2-year apprenticeship, she was involved in the care of many patients with fibroids and severe endometriosis. And you'll hear a little bit throughout the evening from myself. For those who don't know me, I'm the endometriosis nurse coordinator at the Julia Argyrou Endometriosis Centre at Epworth. I support people with known or suspected endometriosis throughout their journey, ensuring that they're supported to access the holistic care that they need. A little bit of housekeeping this evening. As always, we need to preface with the term women, and I use women XN there to encompass that Epworth is proudly inclusive, and there may be times during the webinar where the term women is used, but this is done in recognition of including non-binary and gender diverse people who were born with female reproductive organs. In regards to questions, there is a chat box, a Q&A, which you should be able to click into as you go. Please drop your questions in there throughout the evening, and if they're relevant, then we will address them at the time, but otherwise at the end of the session, we'll have a big discussion time. There will be a recording, and everyone who's registered will be emailed with a copy of the recording once available, and it will also be available online on our website later this week. And in regards to certificates, because there was a lot of interest in CPD certificates last time, please email me, ehendonurse@epworth.org.au with your full name, but bear in mind that there might be a long delay in me getting those back to you. Over to you.
Thank you, Nikki.
I'm just going to jump out.
No worries. So my name's Laura, and I have a growing interest in pelvic health. And with time, I'm seeing more and more people with pelvic health concerns. So nice to be here tonight, and thanks very much for asking me. Yeah. And are you wanting to just, you're going to ask the questions or no? Okay, no problem. All right. So previously, Nikki has given me some questions that she thought would be really interesting to the people at home this evening. So first of all, she asked, what should prompt me to see a GP for pelvic health? And I think the simple answer here is really pelvic pain. And it's pain that is not going away with simple pain relief. So your paracetamol, your ibuprofen, and it's going on and it's causing you issues. It's preventing you from doing things that you would normally be able to do, and ultimately reducing your quality of life. And I think there are a lot of people out there who are experiencing pelvic pain, and they have a confusion over what might be going on and fear of what's happening within their bodies, leading to anxiety. So this is not a good place to be. So this is the type of thing, you know, situation where you would have a chat to your general practitioner. Also with endometriosis in mind, symptoms that are worsening over time, which may initially have just been for a couple of days at the onset of your period, but might be worsening and you know, happening more and more throughout the month, and also with unusual features, which could be not just typical pelvic pain, but also maybe pain in the lower back, pain in the upper thighs. Other than pelvic pain, also if you're having issues with your bladder, so you might be having pain with urination, or you might notice blood in your urine. And with your bowel, you may be experiencing constipation or great deals of pain when you open your bowels. Although prolapse and urinary continence don't really go hand in hand with endometriosis, I just thought I would shine a light on these areas of pelvic health as well, because I feel that there are probably quite a lot of women or people with uteruses who are experiencing symptoms of prolapse and having incontinence issues and really not feeling comfortable discussing these. And so we just want to normalise talking about these types of issues so that you can gain help.
Bring them out of the dark.
Absolutely, yes. Yeah, and then Nikki went on to ask, so what might lead to a high index of suspicion for endometriosis? So as you can see in this slide, this is a resource that we have access to in general practice. And it mentions some of the common clinical presentations of endometriosis. So as many as 60 to 80% of people with endometriosis would be experiencing pain with their period, often starting several days before the period. 10 to 20% experience heavy menstrual bleeding. As many as 40 to 50% are experiencing pain in the pelvis, deep in the pelvis with sex. 10 to 40% are experiencing pain on defecation. Tenesmus, which is a feeling of constantly needing to open your bowels, even when your bowel is potentially empty, and bloating, abdominal bloating. 40 to 50% may be experiencing chronic or also called persistent pelvic pain, whereby you are having pain on most days of the month for more than 6 months. Also subfertility, so people who are not managing to fall pregnant as when they're trying to, so 30 to 50%. And then the urinary symptoms of pain with peeing, blood in the urine, just 5%, lower back or leg pain. So any kind of clustering of these symptoms really might indicate an underlying endometriosis. And also GPs would be bearing in mind the risk factors for endometriosis, which can include being under the age of 11 when your periods first began, having a low BMI, having a short menstrual cycle of less than 27 days, having other members of the family with endometriosis, and also experiencing fertility issues.
Interesting that they don't mention fatigue, because up to 70 to 80% of people are presenting with fatigue as well. And I think that that's why it's possibly under-recognised, because we don't have so much literature to back it up, or it's not so widely recognised as a symptom of endo.
Yeah, absolutely. So that's one of the more maybe non-specific, so less specific symptoms, but it's definitely, yeah, very common with endometriosis. The other thing that gives me pause is people who have sensitized pelvises, so who've been experiencing a lot of pain, but maybe they describe being unable to insert a tampon because it's too uncomfortable, or being very fearful of a cervical screening test because they know the examination is going to be tricky. And with examination, even a light touch examination can be potentially causing quite a lot of pain. So maybe they have become centrally sensitized, we call it, where the messages from the pelvis are being amplified and ramped up in the spinal cord. So when they reach the brain, the pain signal is very strong. So this can be a really unfortunate set of circumstances for someone, can be quite miserable and quite difficult to treat, but there are ways of going on to help with that.
And that can happen before we even know they've got endo.
Absolutely. So That's true, yes, particularly if people have been having persistent pain that they're quite fearful of for years and years. Yeah.
So they
absolutely.
might already be in this kind of situation without even having diagnosis or appropriate treatment at that point.
Absolutely, and that's quite common, I find. I think about 50% of people with persistent pelvic pain have underlying endometriosis. So it can be for other reasons as well, but yeah. That's the main reason.
It's big, isn't it?
Yes.
Yeah.
Question. So yeah, what symptoms does my GP want to know about? And I've put all of them because for lots of reasons, really. But mainly, I think it's so important to let the patient tell you the story of their experiences of pelvic issues. This is a really patient-centered approach, and it's also, I think, quite cathartic for somebody to just be given that time to really go into quite a lot of detail. It's also really useful for the doctor because it means that making some gains in some of those symptoms can be really quite rewarding, and it can be quite helpful for the patient. So although it might be taking time to get in control of the pelvic pain, we can really be helping with irritable bowel syndrome symptoms, or sorting out some of the lethargy that we might find out is associated with iron deficiency, and we can give an iron infusion. So the longer the list of symptoms we have, the more we can start picking off some of those symptoms as quickly as possible, and start to kind of really get a clearer picture of what's causing endo and what's not. Yeah, so just really in that way reducing the kind of disease burden. And I think it also signals that the GP is interested, which I think is really important, to feel that you're being heard as well to move forward. And then also, you know, there's a lot going on in the pelvis, and endometriosis can impact a lot of the structures that you see there. So the bladder, the womb, the bowel, the pelvic floor, and a lot of connective tissue that's not shown on there. So yeah, it really gives us the full picture. And just referring back to Nikki's comment on energy levels and lethargy. So other than the pelvic pain and the bladder and bowel symptoms that I've already mentioned, this slide gives a bit of a summary of the other stuff that we're interested in. With mood, it's understandable that if you're experiencing pain a lot of the month, that it is going to impact your mood. And so also people can be experiencing PMS symptoms or PMDD, so an even stronger form of PMS. And if we can start controlling those things, then it may become easier to manage the pain. Also, if people are experiencing a lot of pain, it can really start to impact their quality of sleep.
It all goes both ways.
Yeah.
Mood, sleep, it's like, which is causing which, chicken or the egg?
Absolutely. So if we can pick one of them and work through it, then it gives us a better idea of, you know, how much it's impacting.
Yeah.
And there's some really great little programs in primary care now that we have access to. We've got a brief CBT tool where we can undertake a short course of CBT to try and sort out insomnia. Yeah, and it's interesting to know what's happening with your energy levels and how you are managing your energy levels throughout the month. And also, are you managing to remain active? And then with the biopsychosocial functioning, really having a lot of symptoms going on is quite a lonely business, I'd imagine. And often people can get into situations where they're finding themselves quite isolated, particularly if they're unable to do everything that they want to do. So it's really useful to just determine exactly what the impacts are. And and also looking at people's coping strategies, which is often reflected in their lifestyle choices. People have functional and dysfunctional coping strategies, we all do, and it's really looking at what they are and kind of using them to our advantage, and with the dysfunctional ones like caffeine, alcohol, maybe under eating or overeating as a coping mechanism. So looking at how we can really understand that and try and help with that. Yeah, so the clearer the picture we can gain, the better we can understand how endometriosis is impacting you and how we might together start finding solutions. And here are the types of diaries that you could potentially bring along to your appointment to your GP. Not only is it giving us lots of information, but hopefully it's helping you tease out what's
like
helping
linking your pain pattern across the month. Do you get flares with ovulation? Like how you mentioned, leading into the period, is the pain increasing at that time? Even how you were saying about the pain going through the legs and things with the pain diary on the previous page. Sometimes that can give us clues in terms of pelvic floor involvement or, you know, other things that pain with passing a bowel motion and things. So I really like those diaries because, like you said, it helps us to pull such a big picture apart and work out almost the priorities, where to start, what can we tackle. Yeah,
absolutely. Yeah, they contain a lot of information. It's quite an efficient way of doing things.
How long would you want someone to do that for?
With the bladder diary, it's only about 2 days can give enough information. With the pain diary, you'd really want a couple of months at least, just to see what the cyclical changes are over time. And then the menstrual one, yeah, we'd want at least 2 or 3 months
You
of
could do
that.
those together and
Yeah,
see
for
what
sure.
the pattern is.
Yeah, there'll be an app that contains all 3 of them. So sorry that I don't have a specific recommendation.
I think the Gwendo app is quite good with cycle tracking, pain symptoms, medication use, that kind of thing. Yeah.
All right, so how can my GP support me to get diagnosed? So really, I think it's providing opportunities for you to talk about your pelvic issues. And there are key times when people do attend their GP, most people, and that would be around family planning, contraception, with your cervical screening tests. And so GPs are encouraged to ask screening questions about people's periods and people's pain. But if you're not being asked, then maybe at times like that, that would be your opportunity to give more information and try and start that conversation. And it's important really that the GP would be kind of listening and validating your symptoms. I think most importantly, GPs should be accessing resources for themselves to ensure that they're following best practice for caring for people with endometriosis. And I've just included the resource to the right, there's the health pathway. So all GPs have access to that, and it has fantastic step-by-step information on how to help and manage and investigate people with endometriosis.
That was the one you showed earlier, wasn't it? About the different symptoms and where to go next.
Absolutely, and it's all specific to the area where you live. So for people who are accessing this in rural communities, your local GP's health pathways will be linking to local
whatever services are there.
Yeah. Okay. Yeah, so it's really good. Yeah, and then GPs are in a good position to start investigating a possible diagnosis. So the most common way of doing that would be organising a specialist gynaecological ultrasound scan. This is usually done transvaginally, so the probe is inserted up the vagina, and this is not acceptable to some people. So in some instances, we might organise an MRI, and also another reason for doing that would be if there were a lot of symptoms, so bladder and bowel symptoms as well. The guidelines do recommend that GPs are speaking to a gynaecologist prior to organising the MRI, just to discuss whether that's the next best step. Yeah. If mild endometriosis is suspected, then GPs can crack on and start using management strategies. But if after, say, 3 months, there isn't any improvement, then that would be a good time to refer to a gynaecologist. There's also other red flag times for doing that, and that's when there is pain deep in the pelvis with sex, if there's pain when opening your bowels, if there is fertility issues and an age pressure in terms of starting a family. But I would say that it's really vital to be seeing a gynaecologist who has an interest in a gynaecologist who has an interest in endometriosis, so has those kind of specialist skills, so that they're kind of wearing the right hat and you know, will help you as best they can. Yeah, and also, you know, using Nikki here as a great resource for working out where to go next in terms of who to see.
Like next steps.
Yeah, exactly. Yeah. Exactly.
I think the thing that stands out for me is if mild endo and you start some initial management, 3 or 4 months, if no improvement, we need to keep going. And I think that's something that, you know, I've seen a lot of, is people have put up with these symptoms for a really long time, or perhaps they've kind of just, the GP's done their best but doesn't quite know the next steps. And I think that's why it's quite important, particularly for my role, to be that bridge between referral to a specialist and saying, actually, let's do a more thorough investigation specific to endometriosis, make sure you get the right scan, refer on to the appropriate gynae based on what the imaging shows, which Al will talk a lot about in her presentation, but not having to put up with it, I think, because I think people put up with a lot more than they need to a lot of the time.
Yes, yeah. 100%. So it's just having those scheduled follow-up appointments, yeah, and keeping a keen eye on, has there been an improvement? Let's look at the diary again. How are you feeling? What do you want to do next?
Yes, and being, you know, confident to say, you know, we've done this, we've tried this, this is how I feel now, it is or it isn't working, what are the next steps?
Absolutely.
Being able to advocate for yourself. And if you're struggling with that at all, get in touch with me, because that's when I can come in to help be an advocate for you as well, by, you know, doing a more detailed assessment, writing to your GP and saying, actually, these are the presenting symptoms that we're still not managing. These are our suggestions. Yeah,
absolutely. Yeah, because at the end of the day, it is a progressive, potentially a progressive disorder.
Yeah.
So time can be of the essence.
And the amount of people, even in today, who have said to me, you know, I had all these symptoms and I did a little bit, but then I was going into year 12 and I didn't want to mess with anything in the year of my final exams. And so they've sit with it for another year, and then their symptoms have progressed a lot. And, it, you know, it doesn't necessarily have to be that disruptive if we can kind of start early.
100%.
Yeah. So you don't have to sit with it.
No, and it's reducing the risk of that kind of central sensitization that we were talking about. Yeah, for sure.
Yeah.
So what assessments will my GP do? So information gathering, like I've already outlined a lot of the information that would be after, potentially looking at those diaries if you've completed them, or giving you some to fill in. Encouraging you to do a questionnaire, and the Pelvic Pain Foundation has an excellent one online. Working out your starting point so that we can, as we've just been talking about, so we can really map those improvements over time. Are you improving? Are you not? If not, what's plan B? Working out your priorities. It's very relevant if you're planning to have your, you know, to start a family ASAP. You know, particularly if there's age pressures on that. It might be that your priorities are very different from the doctor's priorities, so good for us to actually get an idea of what your concerns are and what your expectations are for management. With tests, so I think GPs are quite good at this, at really trying to get all the baseline investigations undertaken, not only to give us the information that we need, but if you go on to see a gynaecologist, it's going to be a lot more efficient for the gynaecologist and for you if you've had all those baseline tests done in the community, so up to date with your cervical screening, any kind of STIs ruled out, yeah, so urinary tract infections, that stuff. Yeah, and then with the examination, I put yes, no, or maybe. It's a bit of a kind of contentious subject because ideally we would examine everybody, but often it's not appropriate on the first meeting, particularly if you do have that very sensitized pelvis. So it's something that we would do with time. But saying that, GPs have always got to have kind of worst case scenario in their back of their mind. So if we didn't feel comfortable, and we thought that we would miss something that needed attention right there and then in terms of sending you off to hospital straight away, then we'd maybe have to do some form of examination. But if you're seeing an endo-friendly practitioner, that shouldn't be too difficult, hopefully.
And do you think if someone who you suspected might be sensitized, you were going to be sending them onto a gynae who you knew would examine them, you just get two birds with one stone?
Exactly.
You wouldn't do it. Yeah,
exactly. Or if I know that they're definitely going to be going for an ultrasound within a week or so, then that would be a reason not to. Yeah.
We do have a couple of questions here. So apologies to the audience, we're having a few little technical issues in case you couldn't tell. So one of the questions that came through, Laura, was pros and cons of hormonal treatment versus Mirena.
Yeah. So Mirena is a hormonal treatment. It has progesterone there, which, yeah, and the idea of hormonal treatment is that it's aiming to suppress menstruation in order to reduce kind of ongoing progression of endometriosis. Yes, but there are plenty of other hormonal options as well in terms of the combined oral contraceptive pill or the Depo-Provera injection, which lasts for 3 months, or the Implanon. But some of them, for example, the Implanon and the injection will only really be helping you or helping the endometriosis if you stop having periods on them, and we can't always guarantee that. Yeah, does that answer that?
I think so, yeah. I suspect, yes. We're just going to have to do a very brief interlude while we switch around some of the logistics here.
Okay, so Nikki, I'm assuming that I'll be doing my presentation now. Beautiful. So a bit of a change to the proceedings, but thank you for that lovely presentation, Laura, and that really set the scene for my presentation to follow. So thankfully, I've got too many slides, so I'll be able to skip over some of them because Laura's covered it beautifully. So first off, Nikki, thank you for inviting me to speak tonight. My name's Alison Bryant-Smith, and as Nikki explained, I'm a consultant gynaecologist. I practice privately out of Epworth, Richmond, and I've completed advanced laparoscopic training with AGIS, and I'll explain what all of that means. Next slide, please, Nikki. So this is a bit of an outline of what I'm going to try and cover. It's a lot to cover in 20 minutes, but you'll be able to look at this video again should you have nothing better to do on a Friday night. I'll start off by describing how I think it would be good to choose between different gynecologists, what to expect when you do see one. And Laura's covered a lot of the history, which is fantastic because we'll ask very similar questions to your GP. Examination and then imaging that a gynecologist might order, in particular an ultrasound. I'll suggest a logical approach, which again is in keeping with what Laura's suggested, and then briefly talk about the role of surgery in diagnosing endo. Thanks, Nikki. So one of the questions that Nikki's asked me to cover is, can I see any gynaecologist for suspected endometriosis? Well, first off, with any clinician, whether it's a gynaecologist or another GP or specialist, word of mouth recommendation, I think, really goes a long way. So if you're having any problems and you think you need to see a gynaecologist, have a chat with your friends, aunties, mother, colleagues, and see if any of them have a gynaecologist that they would recommend. And I would personally value that pretty highly. Obviously, your GP will also have some gynecologists that they would recommend. I'd be cautious with online reviews. I've looked up reviews of colleagues sometimes for a laugh, and there's not always a great correlation between their reviews and my professional opinion of them. So I just take any online reviews with a bar of salt or grain of salt. Thanks, Nikki. One key question which I'll flesh out a little bit is, in particular in the context of endometriosis, is has the gynaecologist you're planning to see undertaken additional training in laparoscopic gynaecology? In particular, what's called an AGIS fellowship. So AGIS, and you can see the picture here in the bottom right-hand corner, stands for the Australasian Gynaecological Endoscopy and Surgery Society. It's quite a mouthful. AGIS is essentially the peak body in Australia for keyhole gynaecology surgeons. And they have a 2-year training program, which essentially is an apprentice with a senior surgeon as your mentor to learn how to tackle the most challenging gynecological conditions, which surgically is stage 4 or severe endometriosis. That fellowship program has only been around for about 10 years or so. So any older gynecologists than that didn't have the opportunity to do an AGIS fellowship because it didn't exist. But people who have completed, their basic training as an obstetrician gynecologist in the last 10 years, if they've got an AGIS fellowship to their name, I would seek that out if you're seeking an advanced surgeon. And as always with any clinician, I think a relaxing bedside manner goes a long way. You really need to develop that rapport and develop a trusting clinical relationship with your gynecologist. Thanks, Nikki. In terms of whether it's appropriate for you to see a general gynecologist or an advanced laparoscopic surgeon, I'll just quickly flesh out. So you can see in the bottom right-hand corner there, the College of Obstetrician Gynaecologists has produced these guidelines for performing gynecological endoscopic procedures. And they outline 6 different levels of difficulty of keyhole surgery, from level 1 being the most basic, straightforward keyhole surgery to level 6 being the most challenging. A generalist gynecologist, so someone who has completed the 6-year training program of the College of Obstetricians and Gynaecologists, should be able to perform levels 1, 2, and 3. So level 1, which is called a diagnostic laparoscopy, is essentially putting a video camera in a woman's tummy, having a look, taking some photos, and leaving it at that. So they're not actually doing anything. They're not actually cutting out any endo, even if they do see it. Level 2 is excision of minimal or stage 1 endometriosis. Level 3 is excision of stage 2 or mild endometriosis. So again, if you're suspected to have minimal or mild endometriosis, it would be appropriate for your GP to refer you to a generalist gynecologist. Thanks, Nikki. On the other hand, if you're suspected to have moderate or severe endometriosis, you really need to seek out a gynecologist who's had some advanced training, because a general gynecologist won't have this, or may not necessarily have the surgical skills and know-how to be able to do the best by you. So level 4, based on this Ranscog College level system, is excision of stage 3 or moderate endo. And for this, the college recommends that the gynecologist has completed what's called an advanced training module. This has only been released by the college in the last few years. So again, only the most junior of gynecologists will have been able to complete this. Levels 5 and 6 are appropriate for the most severe endometriosis, and in particular level 6 if there's any bowel or ureteric involvement, the ureters being the tubes that go from the bladder, the kidneys down to the bladder. And for level 5 and 6 keyhole surgery, you really need to seek out a gynecologist who's had that advanced training. The risk if you don't is that you may have a generalist who pokes and prods around a little bit, but is a little bit out of their depth and potentially might run into trouble. You run the risk of needing 2 keyhole surgeries if you have a first keyhole operation with a gynecologist who doesn't have the skills necessarily to do what needs doing, and then needs to refer you on to an advanced surgeon. Thanks, Nikki. So the first of a few take-home messages for tonight. If you're suspected to have moderate or severe, so stage 3 or stage 4 endometriosis, it would be worth your while finding a gynecologist with additional training. Thanks, Nikki.
I'm going to jump in there and say, that if they come to my clinic, we can often, I mean, not always, obviously, and based on our imaging, we can make better decisions, but we can help make sure we direct people to the right gynecologist based on their symptom assessment, the severity of the symptoms, any previous imaging they've had. And if there's any suspicion of bowel involvement, I would always send them to AGES trainee or someone with particular special interest in bowel cases as well. So it's good that we can tease those things out.
Good to know. Thanks, Nikki. And next slide when you're ready. Thanks. So the next question Nikki's asked me to cover is what's involved in an initial gynecology review for suspected endometriosis. So I'll cover this with history, examination, and then imaging, principally ultrasound. Thanks, Nikki. And the next slide, please. So first off, history, and this is really in line with what Laura's discussed. So a gynecologist, when you first see them for the first consultation, should ask about your past medical and surgical history, your menstrual history, so when did you go through menarche, which is the age at which women start getting their periods, how long they bleed for every month, and then how long is their menstrual cycle, so from day one of one period to day one of the next. Do you have any heavy periods? And most importantly for endo, do you have any period pain or dysmenorrhea? Thanks, Nikki. In terms of period pain, the gynecologist really want to clarify, so the timing of the pain. Classically, women with endo, their period pain starts a day or two before the actual bleeding of their period. The character is often described as a cramping, twisting sort of pain, and the severity can range from anywhere from 0 to 11 out of 10. The location classically is central pelvic cramping, but it can be off to one side or the other if there's an ovarian cyst, and sometimes there can be radiation. So for example, down the front of your thighs or around to the lower back. We also want to know about what's called non-cyclical pain, so pain between your periods in either the abdomen or pelvis. As Laura's alluded to, there can be nausea and vomiting, and tiredness and fatigue can also be a key symptom. Really important for any surgeon is what you've tried in the past for your symptoms and did it help with your symptoms. So as Laura's alluded to, a good GP, such as Laura, will start off with symptomatic management. So pain relief tablets like naprogesic is probably the most effective, mefenamic acid, which is known as the brand name Ponstan, and then hormonal suppression. So any sort of hormone that's going to dampen down that inflammatory response and slow the growth of the endometriosis. And classically, we tend to use a contraceptive pill, an intrauterine device like Mirena, or an Implanon. We'd also really love to know if you've had keyhole surgery in the past, what did the surgeon find? Did they cut out endometriosis, and did your symptoms improve? Next slide. Thanks, Nikki. So the next of my take-home messages, if you have had keyhole surgery in the past, if you can, before you see your next gynecologist, it's really, really helpful for us if you can please try and source any notes from your previous surgeon. So the operation notes of what they actually did and what they found. Any photos that they took at the keyhole surgery is also absolute gold for us, and any histopathology. So if they've sent off any specimens of endometriosis to the lab, it's really great to get those lab reports if you can get your hands on them. I realise it can be really challenging to get that information from previous surgeons and previous hospitals, but if you can try, your future gynecologist will really help you. I'll thank you for it. Thanks, Nikki. So in addition, some more questions that the gynecologist might ask, and Laura's alluded to these, is symptoms of what's called DIE, and that stands for deeply infiltrative endometriosis. So endometriosis that grows into bladder, bowel, and ureters. A key symptom of that is dyspareunia, or pain with penetrative sex. Some additional symptoms which I routinely ask about are bowel symptoms, so in particular cyclical changes to your bowel habit. So classically, women with bowel endo will have a normal bowel habit most of the month, constipation before their period, and then a looser bowel habit with their period. And if that's the kind of habit that a patient's having, that's a red flag to me that she may have bowel endometriosis. Additional red flags are things like having blood in the stools during your period, or some women describe a shooting rectal pain when defecating when they've got their period. And again, these are things that a good surgeon should ask about routinely, just to try and risk assess how likely you are to have bowel endo. Next slide, thanks, Nikki. We'd also ask about bladder symptoms, so getting a real urgency that you can't hold on when you do need to wee, and emptying your bladder more frequently than others, and pain when emptying your bladder. Subfertility, we've mentioned, can be a sign of endometriosis. So if you're under 35 years old and you've tried to conceive for 1 year and haven't been able to, that's a red flag. If you're 35 or older and you've been trying for 6 months and haven't been able to, again, that's a red flag and can be a symptom of deeply infiltrating endometriosis. Next slide, thanks. We've mentioned already a few different surveys and tools that you can use to track your symptoms. This is another one I just like to throw into the mix. It's produced by the College of Obstetrician Gynaecologists, and the acronym is RATE, Raising Awareness Tool for Endometriosis, and I've got the link there. Essentially, it's an online survey of endometriosis symptoms that you as a patient can fill out, print out, and then take to your GP or gynaecologist. And it's really helpful, like Laura said, that we do a baseline survey and get some objective evidence, I suppose, of what your symptoms are like at the start of your treatment. Try some implement some management strategies such as the pill or Mirena, pain relief, something like that. Repeat the survey a few months down the track, and then you've got a really good record as to how your symptoms have improved, if they have, and hopefully they have. Next slide, thanks, Nikki. So the next take-home message is it's really helpful before you see a gynaecologist if you can think about answers to the questions that I've run through and keep a symptom diary, which Laura's alluded to. The Q Endo app is excellent, or a lot of the apps like Flow, FLO, that a lot of women use to track their periods also have tabs that you can keep track of things like period pain and other symptoms. Next slide, thanks. So moving on from history to examination. So a lot of gynaecologists will ask to perform a vaginal examination. Keeping in mind this is obviously quite a sensitive examination and they need to have your permission and to explain what they're doing, and also have a chaperone in the room, such as a clinic nurse, just for your moral support. What this involves is one hand on the outside of your tummy, 2 fingers inside the vagina, and then what they're really feeling for. So one of the things is any particular areas of tenderness, what's called focal tenderness, which might be due to an endometriotic nodule on the other side of the vagina, so essentially in amongst the internal organs. Thanks, Nikki. They'll also be feeling to see if the uterus is what's called anteverted or retroverted. So anteverted, which is on the left side of that diagram there, is when the top of the uterus flops forwards towards your belly button, and that's normal, so the majority of women have that. In contrast, so a retroverted uterus is when the top of the uterus flops backwards towards your spine, and that can be due to severe endometriosis. Essentially, endo behind the uterus causes internal scarring and then hitches the uterus backwards. And again, that's something that we should try and feel for during a vaginal examination. Thanks, Nikki. In addition, we also try to see if the uterus is what's called mobile or fixed. So the photo here down the bottom is a perfectly normal pelvis without any endometriosis at all. The big sort of blob in the middle is the uterus, and then there's fallopian tubes going off on either side. It's sort of 4 o'clock and 8 o'clock. And then at the back, you can see the bowel coming in at 6 o'clock. So that's a normal pelvis. Compare that to the right, where even a laywoman can tell that their uterus looks reasonably normal, but there's a whole lot of mess and everything all jammed up and stuck at the back there. So that's essentially a big endometriotic cyst in the right ovary that you can see labelled. The bit just to the left of that is the bowel, and so that's internal scarring with the bowel stuck to the back of the uterus. And that's what we call an obliterated pouch of Douglas, which is just a technical term saying that that big open space between the bowel and the uterus is completely jammed shut with internal organs all scarred against each other due to endo. This is the kind of thing that we can try and determine during a vaginal examination by getting a sense as to whether the uterus is nice and floppy and free and moving around when we wiggle our fingers, which it should be, that's normal. Or if it doesn't and it's stuck like glue, again, that's a red flag for us that you might have moderate or severe endo. Thanks, Nikki. We'll also feel to see if there's any palpable endometriotic nodules. So the photo here is what's called the uterosacral ligaments, and that arch are the ligaments between the back of the uterus, which is at the front of that picture, and the sacrum or your tailbone at the bottom. And you can see that black smudge there on the left side of the arch. That's an endometriotic nodule on the left uterosacral ligament, and that's something that we'll try and feel during a vaginal examination. Having said all of that, if you have a normal examination, it doesn't mean you don't have endo. And that's where imaging comes into it. Thanks, Nikki. So with imaging, one of the questions I was asked to cover is, can an ultrasound or other imaging confirm if I have endo? So I'll start off first discussing a basic pelvic ultrasound. Next slide, thanks. And again. Great. So a basic pelvic ultrasound There's a huge spectrum as to the quality of scans that we get. Part of that is different companies are better at them than the others, and different sonographers or technicians are better at scans than others. Generally, an average basic pelvic ultrasound will be told the volume of the uterus, the volume of the ovaries, and if there's any endometriotic cysts on the ovaries, what are called endometriomas. And they're a finding of at least stage 3, so moderate or severe endo. That's essentially the sum total of the information we'll get from an endometriosis point of view. There's a Medicare rebate available, and there may or may not be an out-of-pocket cost. Thanks, Nikki. So the takeaway there is that a basic pelvic ultrasound can really only diagnose endometriomas. So it's of some utility, but not a lot. Thanks, Nikki. That's in contrast to what's called a DIE ultrasound, which stands for deeply infiltrative endometriosis. This is also a transvaginal ultrasound. It takes longer, so it takes about 15 to 20 minutes. And some companies ask that you do bowel prep, so strong laxatives the night before. And there is an additional out-of-pocket cost of about $280. I would argue that's money well spent, but that's easy for me to say because it's not my money. I'll explain the difference it makes to me as a surgeon and hopefully also to you as a patient. It's tremendously helpful for us as endometriosis surgeons because having a DIE ultrasound essentially maps out exactly where your endo is in your pelvis. So you can see on the right here, we've got the black and white images from the DIE ultrasound and then the correlating diagram of where the endo actually is. So essentially a good DIE scan will tell us as advanced gynaecology surgeons exactly where to expect the endo when we put the camera in your tummy to do the keyhole surgery. And that information is absolutely priceless. The difference that makes to us is that it might save you having 2 laparoscopies rather than 1. So for example, it might save you from having a diagnostic laparoscopy with a generalist gynaecologist who just puts a camera in, takes some photos, gets a bit scared and leaves, and then refers you on to us. It also makes a difference between us as an advanced laparoscopic surgeon involving our colorectal surgery buddies or not. Because if we have a DIE ultrasound that says this woman most likely has an endometriotic nodule on her bowel, that's out of the scope of practice of even an advanced gynaecologist, and we would phone a friend and ask you to see our colorectal surgery friend and then ask them to attend when we're doing your operation. So it's a joint operation with gynecologists doing the gynecology and colorectal surgeons in managing the bowel endo. And again, that's one way that a DIE ultrasound might save you from having 2 operations, so we can do a joint case with all the surgeons there at the same time. Thanks, Nikki.
Al, we've got a question here. Someone said they were diagnosed with endometriosis without having any surgery. Is that possible? So you've basically just talked to that, but do you want to elaborate a bit for us?
Yeah, it's a great question. So essentially you can be diagnosed with suspected endometriosis without having surgery. And that's a perfectly valid approach. But strictly speaking, you can't actually be diagnosed. You definitively do or don't have endometriosis unless you've had keyhole surgery and someone's had a look in your tummy with a video camera. So you can certainly have suspected endo without having surgery, but you can't have a definitive, guaranteed diagnosis, yes or no, without keyhole surgery. Good question.
Thank you.
Thanks, Nikki. Next slide. Beautiful. So the information that we get on a DIE scan that helps us make that decision, we get uterine volume, which you also get in a basic scan. You also are told whether it's anteverted or retroverted. You're told if there's fibroid, you're told if there's adenomyosis. Moving on to ovaries, in addition to volume, we're also told if there's any ovarian cysts, if there's tenderness, so if it's painful when the probe is near an ovary, and if the ovary is moving or if there's internal scarring. And again, that's really suggestive of endo near the ovaries. They also look at the uterosacral ligaments, which was the diagram I showed earlier, and can see nodules and tell us about tenderness. Next slide, please. They'll also look at bladder, ureters, and endometriotic nodules in the bowel. They also assess what's called the sliding sign, and essentially that's whether or not the bowel slides freely on the back of the uterus, which it should, or is it completely stuck up and jammed by internal scarring, which it shouldn't. So like I've been alluding to, a DIE ultrasound can really differentiate between minimal and mild endometriosis on the one hand, which is the top 2 diagrams there, or moderate and severe endometriosis on the other hand, which is the bottom 2 diagrams. Next slide, thanks, Nikki. Having that information helps a GP determine whether the best gynaecologist for you is a generalist who has the surgical skills for minimal or mild endo, or whether they need to refer you to an advanced laparoscopic surgeon who has the skills for moderate or severe endo. So it's a really good triage tool for GPs. Thanks, Nikki.
You're really expanding on the why we love a good DAE scan here.
Absolutely. Like I said, I think it's money well spent, but that's easy to say when it's not my money.
And if you can do it once, rather than have that initial ultrasound that doesn't tell us much and then have to go back for an additional scan, and if you can have it done before you see the gynecologist,
Absolutely.
it also saves you an additional trip to the gynae first. So we talked about all of that in my clinic.
Yeah, you're speaking my language there, Nikki. So moving on, so like I was saying, so in addition, a DAE ultrasound also helps the gynecologist decide whether or not they need to get their colorectal colleagues involved. Thanks, Nikki. So take home message here. So DAE ultrasound really helps your gynecologist plan the best operation for you from the get-go. And in addition, as Laura's alluded to, and I'm glad that we're both singing from the same songbook here, if a patient has bowel and or urinary symptoms and or they're found on a basic pelvic ultrasound to have an endometrioma, that endometriotic cyst in the ovary, there's a really good reason to organise a DAE ultrasound to see if there's any other involvement. So I have no financial affiliations to any of these ultrasound companies. I have nothing to gain from you having a DAE scan with them, but I know from experience that they've got really good clinicians who do really good quality scans. Thanks, Nikki.
I've also got a list that includes a couple more that we've sort of done background checks on. And so I always try and send someone to someone local or easily accessed as well, so I can help with that part.
Yeah, because not all radiology companies can do these kind of scans. They are quite specialised. So you can't just rock up to your neighbourhood IMED and ask for a DAE scan. You really need to seek out a women's health scanning company in particular. So moving on from ultrasound to MRI. So like Laura's alluded to, there is certainly a place for MRI in endometriosis. Similar accuracy as a transvaginal ultrasound. The role that it plays, I suppose, in diagnosing endo is it's helpful for women who don't feel comfortable having a transvaginal ultrasound, and MRI is non-invasive. Sometimes ultrasound views can be limited by really high body mass index, and so MRI can help with that. I need to acknowledge that not everyone has access to a DAE ultrasound, particularly in rural cities or regional areas, and that's, again, women may have easier access to an MRI machine. And the rare case where there's endometriosis outside the pelvis. So you do see rare case descriptions of women with endo in the lung, for example, which isn't going to be picked up by a transvaginal ultrasound. Next slide, please. So one of the last questions, I'm wrapping up, and then I'll hand over to Nikki for her presentation. Do I need surgery to diagnose endo? And that's partly what I think the listener was asking earlier. So by definition, laparoscopy is the gold standard for diagnosing endometriosis definitively. It allows us to visualise the endometric nodules directly with our camera, excise them, cut them out, and then send them off to the lab for the pathologist to look at under the microscope. Part of that is because superficial or shallow endo, such as the stage 1 minimal and stage 2 mild, may not be visible on imaging. And that's really, whoever works that out will get the Nobel Prize for Medicine. We'll earn a lot of money, because I would pay good money to have an ultrasound that showed minimal endo. Now, the next slide is going to be a bit controversial, and some of my gynecology colleagues might not like me for saying this, but I would argue that you don't always need keyhole surgery. And this is someone who loves operating. I would operate all day, every day if I could, but you don't necessarily need to have keyhole surgery. And this is similar along the lines to what Laura was saying. So if you've got bad period pain, take a symptom diary for a few months, see your GP. They hopefully will try the simple things like pain relief, naproxenic and mefenamic acid or Ponstan. They will probably recommend some hormonal suppression to slow the growth of the endo. And if doing all of that resolves your symptoms completely, and if you're not trying to conceive, I would argue there's no need to have keyhole surgery, because your symptoms are better, you're not trying to conceive, you can leave it at that. And again, some of my gynecology colleagues might resent me for saying that, but I'm giving away a bit of a trade secret there. Next slide. Thanks, Nikki. So this is really the logical approach, again, in line with what Laura's recommended. Keep a symptom diary or complete the rate survey that I alluded to. See your GP, trial the medical management for, and I would say 3 to 6 months, and then see your GP again and just assess your progress. Thanks, Nikki. Like I've said, laparoscopy is the gold standard for diagnosis, but it's not always needed. Next slide, please. If you get to that next review with your GP at the 3 to 6 month mark, do you mind just going back one, please, Nikki? Thanks. So if you get to that next review with the GP after 3 to 6 months of trialling pain relief, hormonal suppression, and you've got ongoing or worsening symptoms, you could then think about having an ultrasound. So you could start off with a basic pelvic ultrasound and find somewhere that does a Medicare rebate so you're not out of pocket. If you have bowel or urinary symptoms, then like Laura said, we'd recommend a DIE ultrasound. If no endometriosis is seen on that imaging, we're assuming that you have minimal to mild endo, so you can see a generalist gynaecologist. But if there's a suspicion of moderate or severe endo, it's worth seeing someone with a bit of additional training. Thanks, Nikki. I think this is about the last question. What's involved in surgery for suspected endo? So keyhole surgery or laparoscopy. So it's 1 scar at your belly button for the camera and then 2 to 3 smaller scars for our surgical instruments, like in this picture here. And the aim of the surgeon should really be to completely excise or cut out all endometriotic nodules. There's a bit of debate online about excision, which is cutting out, or ablation, which is just a superficial burning. There's really good evidence that excision, cutting out the endo, provides much better symptomatic relief and better fertility outcomes. The analogy here is that you've got an endometriotic nodule that's like a weed growing. The ablation just cuts off the plant, but it leaves the roots, whereas excision takes off the plant and also digs out the roots. Thanks, Nikki. So non-surgical management, what can I do to manage if I don't want any surgery? And these are many of the things we've already talked about. And Nikki's a fantastic resource to link you in with these clinicians. So such as a pain specialist, women's health physiotherapist, and a health psychologist, in addition to the analgesia and the hormonal suppression we've already discussed. Thanks, Nikki. And I think that's about it. And I'll look forward to Nikki's presentation and then the questions that follow.
Perfect. We lost a couple of slides in the changeover and the merging of the two packages. So basically, I think I've kind of mentioned my role throughout, but I have a nurse-led clinic. It's free to access. It's mostly via telehealth because of COVID at the moment, and also because I see a lot of people who live far and wide within Victoria. If you would like to see me in clinic, please complete a referral form on our website and email it to ehendonurse@epworth.org.au, and I will make a time with you to have a telehealth. We'll talk through kind of the more in-depth stuff after what you've done and do a really thorough systems-based assessment on, you know, how things are going, where you're up to with your menstrual health, pelvic health, pain, fatigue, etc. I put that all into a letter and I send that back to your GP and to whichever specialist we refer you on to. Make any suggestions in regards to further imaging within my scope, obviously, and sometimes we'll just leave that up to the gynaecologist in terms of if they want more detailed imaging. And then usually we have a touch point after you've seen the gynaecologist and you've had your various other appointments. We have touched on allied health. We haven't probably gone into too much detail on that because this is focusing on getting the diagnosis, but I also look more broadly at other impacts on your life and how we can optimize those things, particularly mood, sleep, pain. We've talked a lot about physical activity, pelvic floor. We do a lot of pelvic floor physio referrals. So we go through all of those things. It's very thorough. It usually goes for about 45 minutes to an hour. So that's my role, and then I'm always here for ongoing support. If you end up having surgery at Epworth, I can come and see you on the ward. I can do post-op follow-up with you. We also run the endometriosis support group, so if you kind of suspect that you've got endo or you're newly diagnosed, feel free to join us. And lots more resources like this coming available along with our other online resources, the endometriosis patient guide and the pain guide. So do keep up to date with our newsletter. You should get that now if you've logged into this, and keep up to date with the various goings on in the centre. But we just want to open it up to the floor now, and please bear with us because we're having trouble viewing the questions. So let me read them out. Al, might be best if you could answer this. How long could Vizan be taken for an endometriosis?
Sure. I have turned my camera on at my end.
Yeah, we might have to flip back to
a
your,
white
otherwise you
screen.
can just answer people shouting.
Yeah, sure. Absolutely. So essentially, Vizan is a brand name for those who don't know of a progesterone called Gynaecology, which is contained in some contraceptive pills. But the Vizan essentially is a progesterone only pill. There's some reasonable evidence that Gynaecology is a good progesterone for women who have endo to consume, in that it's better at controlling their period pain than other types of progesterone in different pills. You can essentially take the Vazan, the progesterone-only pill, indefinitely. So when it was first released, there was a good study from a German-speaking country, so either Germany or Switzerland, I think, that studied women for 5 years taking Vazan, and there were no significant side effects and really good symptomatic response. So essentially, you can take the Vazan indefinitely until menopause if needs be.
Great. Do we have to add there around the licensing in terms of contraception for Vazan?
Yeah, good question. Thanks, Nikki. Thanks for prompting me there. So Vazan isn't licensed for contraception, so you shouldn't rely on Vazan for contraception. You'd need to use barrier contraception such as condoms or something similar. Having said that, it does effectively act as contraception, but you just shouldn't rely on it to act like that.
Okay, cool. We've got another question here that asks, does the pill help reduce the size of endometriosis?
Yeah, good question. So working on the basis that the main mechanism or theory that causes endometriosis is what's called retrograde menstruation. So essentially, when any woman has a period, it's the lining of your uterus shedding out through the vagina that you get bleeding outside. In some women, for some reason, and we don't quite know why this happens, some of that lining goes the wrong way through the fallopian tubes, and then you end up with these collections of menstrual blood in amongst your pelvic organs. And essentially that's what an endometriotic nodule is. It's a collection of old menstrual blood that's come through the fallopian tubes and then develops local inflammation. So logically, any tablets you take that lighten your periods should slow that process. So contraceptive pills tend to lighten periods. Tranexamic acid is a non-hormonal tablet that lightens periods by about 40%. Having a Mirena intrauterine device is a really good way to lighten your periods. So all of those hormones will slow the ongoing additional growth of endo, but they are unlikely to shrink any nodules that already exist.
Yeah, so it's more about kind of ongoing prevention rather than reversal of lesions.
Yeah, and the way I tend to explain the sort of lifelong management of endo to patients is to say that there's two prongs. One prong, if appropriate, so if you've tried the medical management, the tablets, and you've still got ongoing symptoms, one prong is keyhole surgery to essentially cut out any endometriosis that's there already and give you sort of a clean slate, so to speak. And then the second prong is some sort of hormonal suppression after the operation to slow the regrowth. Because it used to be the done thing that you'd have your annual clean out and have your annual keyhole surgery. That's really bad practice. What is best practice now is that you have one keyhole operation with one really good surgeon, get a clean slate, then have some hormonal suppression to slow the regrowth, and hopefully never need another keyhole surgery again. Yeah. So that's what we'd aim for.
Yeah, absolutely. Here's a question along that same vein. After having keyhole surgery, is there a possibility of having endometrial cyst again?
Good question. So that comes back to the idea of hormonal suppression. So if I see a patient who's had keyhole surgery in the past, first off, I want to know what her symptoms were like before the keyhole surgery, what the surgeon found, what they cut out in terms of endo, and then if any hormonal suppression was started at the operation. Because if she's had keyhole surgery and all the endo was excised and she's got a clean slate or blank slate, but no hormones were started, then every period she has, that retrograde menstruation process will continue and those nodules will build up again. So it's certainly, it's probably likely that if you've had keyhole surgery and you've had all your endo cut out, but you don't have any hormones, that process is going to start again. And then a few years down the track, you may well have more nodules that have developed.
There's a question here. We might need the author to clarify. They've said, is it fair enough to not have the pain management and hormone? If I've done that in the past, it did work, but I'm now 38 and I've had 3 failed cycles of IVF. I think this might refer to, should we go down the surgery route?
Yeah, and it's a good question. And I think it's really good if you can to find a gynaecologist who's got good links with a local IVF clinician. So when I did my Aegis Fellowship in Sydney with a guy called Professor Alan Lamb, who's quite esteemed in the endo world. He had really good connections and good working relationships with 2 IVF clinicians, and they would often refer patients between each other. And it really worked both ways. So sometimes patients would present to the IVF clinician first. They would try a few cycles of IVF, not be successful, and then the IVF clinician would refer to Professor Lamb with suspected endometriosis. Can you please organise the ultrasounds and, if relevant, do the keyhole surgery? Sometimes it would work the other way around, that patients who couldn't conceive would come to our gynaecology clinic first. We would do the keyhole surgery, cut out any endometriosis, suggest that the patient tries to conceive for an additional 6 or 12 months, depending on her age, and if not, see the IVF clinician. So ideally, it's that whole idea of having a multidisciplinary team looking after you. And again, that's best practice. If you can find a gynaecologist who's got good links with an IVF team and can refer as needed, either before or after surgery.
Yeah, thanks. A question now for Laura. So my daughter is 13. We suspect she may have it. Is it common in young people?
I wouldn't say it's common, but I think it's becoming more recognised as a possibility at that age. And I think studies are showing that if you do have it at a younger age, you're likely to wait quite a bit longer for diagnosis. So, you know, if you have concerns, definitely important to see a suitable healthcare provider to work out what's going on there. Yeah.
And like what we were saying back in the beginning is not to sit with it for too long. Yeah. No,
exactly.
it's okay to escalate and to keep prompting for that if you monitor those symptoms and things aren't improving. Another question, painful endo and fertility issues. Is a gyno enough support, or should I be seeing another professional? I know what I'd say.
Well, I want to hear what you're going to say, Nikki. Yeah, absolutely.
The more the better. Yeah, I think. Yeah, I mean, there's so much within that without even asking the question. There's psychological component to going through fertility treatment. There's all of the other aspects that involves and the impact that plays on your body when you undergo fertility treatment. In addition to having painful endo, is there pelvic floor dysfunction contributing to that endo pain? Yeah, there's a lot to unpack. Come and see me in clinic. We'll just see if there's any more questions coming through. We'll give it another minute or two, but thank you so much everyone for your questions so far. They've all been really great questions, and it's nice to see so much engagement. I have had 6 keyhole surgeries and I'm trying for a baby. How do I stop it? I assume they mean the endo from coming back when trying to conceive. Yeah,
that's a really good question. So quite often women who are trying to conceive and have suspected or known endo are really stuck between a bit of a rock and a hard place, because the hormonal suppression that we recommend to slow the growth of the endo is essentially all contraception.
Yeah.
So unfortunately, you can't have it both ways. You can't be off contraception and trying to conceive while on contraception to try and slow the growth of endo. And that's a real catch-22 that unfortunately is really difficult to navigate. So what I would recommend, if I see a patient who's known to have endometriosis, so say she's had keyhole surgery by a previous gynaecologist in the past, is currently on the contraceptive pill and that's working well for her, but she wants to conceive soon, we know that she has a tendency to develop endo. So essentially what I would recommend is that she stays on the contraceptive pill right up until she wants to try and start actively trying to conceive, tries to conceive, hopefully conceives within, not too long a time frame. Once she's pregnant, she obviously won't be having periods. If she's breastfeeding, she won't be having periods. So again, that process of retrograde menstruation won't be occurring because she's not menstruating. Once she's had her baby breastfeeding, not having periods, once she starts having periods again, to go straight back onto hormonal suppression. So either the progesterone only pill if she's breastfeeding, or the combined estrogen and progesterone pill if she's no longer breastfeeding, to try and slow that process from occurring again. So try to slow the growth of endo. But it can be really tricky, and I don't know any easy answers to women who have a tendency to develop endo and also wanting to conceive, because there's those conflicting tensions there, which is really hard to navigate.
And from your perspective, Laura, how would you manage?
I would be wanting fertility specialists to be involved from the get-go, kind of lined up almost for as soon as they stop the pill, which may or may not be possible.
And probably having a lot of planning before it happens, and having that discussion with your GP, saying, you know, I'm going to try and conceive, we've got this plan, get the referral in the work so that if not pregnant by 6 months, you proceed through to a fertility specialist.
Yeah, I agree, Nikki.
Just trying to keep that window as short as possible.
And in addition to that, you could, the GP, a good GP, would be able to institute various investigations to see a possible source of the subfertility. So if you know that you've got endo and you know that you might run into trouble conceiving, there's a few things that you can do. So if you think about it on a basic level, a cis couple needs 4 things to conceive. They need eggs, open tubes, a normal uterus, and normal sperm. So if you know that you might run into trouble conceiving, your partner could do a semen analysis to make sure the sperm are normal. You could ask your GP to organise a blood test called an AMH, or anti-Müllerian hormone, which is a good test of ovarian reserve. That can be low in endo. So if you know that you've got endo and you've got a normal AMH, that would be encouraging. You could have a basic or a DIE ultrasound to make sure your uterus is normal. In terms of the tubes, you can have an investigation called an HSG, or hysterosalpingogram, which is a bit uncomfortable, but essentially it's almost like x-rays while they're putting some fluid through the cervix to make sure and watch the fluid come through the fallopian tubes. Because the fallopian tubes aren't glued shut to the ovaries, they're floating freely, and so there should be fluid floating through the tubes. So that can all be done while you're on the pill and before you start trying to conceive, and that might give you an idea as to how likely you are to run into trouble conceiving. And that's the kind of investigations that a GP or fertility specialist can arrange, and then guide you from there whether or not you need to see a gynaecologist.
Yeah, the other thing I would suggest as well is just understanding about fertile window.
Time to intercourse.
Exactly. So although that can lead to performance anxiety, it's probably still quite important to understand how you're going to maximise your chances. Yeah.
I agree.
Laura, I think you mentioned this one earlier. Does having relatives with endometriosis increase your chances of having it also?
Yes, it does. Yeah, I'm not sure by what percentage. You might know, but certainly.
No, I don't off the top of my head, but there certainly is a familial preponderance. Yeah, and so quite often we see patients whose mum was known to have severe endo, and hopefully then has a lower threshold for helping their daughter through that process.
I certainly see that the mums bringing them in their mid-teens, which is you know, a lot sooner than they were able to access treatment. So it is shifting.
But I think that can also work both ways. You know, that to some extent women with really terrible period pain, I'll say, well, my mum said that she had terrible period pain and just to put up with it. You know, and so I think that can work both ways.
Yeah. There's a question here. It says laparoscopy only, brackets diagnostic, suspected stage 3 or 4 based on symptoms. Does this mean likely to have a laparoscopy and then close up and then scheduled for another? It sounds to me like that's what it might be saying. Without seeing the consent form that you've done of the booking, that's something that you would need to clarify with the surgeon, and it's something you would definitely want clarified in advance enough to know whether you need to be referred to a more suitably qualified surgeon, or whether having that extra imaging would help them make that decision and get you on the appropriate list. I think Alison, in the private, sorry, would you say that they do any diagnostic laparoscopies, or would this be more what we see in the public?
I'm trying to be diplomatic here. It's not best. It's not best practice. We just shouldn't be doing it. Okay, we need to have a good sense before the patient gets on the operating table, the likely severity of their endo, and then we need to make sure we've got the right surgeon with the right patient at the right time. So I am really firm putting my foot down and saying we're not taking this woman to theatre for a diagnostic laparoscopy. We need better imaging. We need to get her in good hands. And I think that whether that's public or private, it should be the same approach.
Yeah, I really feel, and this is even just from a nursing perspective, that we have got enough technology at the moment. Access is a different story, but we have the technology that we should never be surprised when we get into theatre.
I agree. And even with access, if you live in a country town and you don't have access to a DID scan, ask for an MRI. get a telehealth appointment with an advanced keyhole surgeon in your local regional centre. You know, Ballarat's got great surgeons, Geelong's got great surgeons, for example, or even in Melbourne, if that's the closest centre or closest advanced laparoscopic surgeon to you. And, you know, I've had patients in that sort of situation where I meet them for the first time on the day of their operation because they've travelled for hours. But we've done a really thorough workout. I feel like I know them really well, and hopefully they feel like they know me reasonably well. And we've got a really good trusting, you know, rapport and relationship.
Yeah.
But you can, you know, joys of Zoom. If there's any silver lining to COVID, we can do telehealth and we can do all of that remotely.
Yeah. We'll just do a couple more because I'm very wary. We've gone well over time. Pain and pelvic pain not during period. This is pelvic floor red flag to me.
Please continue, Nikki.
That's literally the question. Yeah. I would say, yeah, to me, that sounds like they've probably got an overactive pelvic floor that's been activated from being in pain for such a long time and is now ultra responsive to any type of stimulus, which may or may not be triggered by a biomedical cause. And we need to assess that appropriately, make a plan, retrain how to relax those muscles and stop that kind of clench pain cycle that can be difficult to break initially, but once we get on top of it, can be really useful for pain. Come and see me.
I agree. Can I just add something there? So when I see patients whose main symptom, so they have period pain, but their main symptom is pain between their periods, there is a question, well, endometriosis, strictly speaking, shouldn't really cause pain between your periods. So is there something else going on, like the central sensitization that you've alluded to? A bit of a diagnostic test that I sometimes do there is offer women the choice of going on what's called Zoladex, which is a monthly injection that puts you into a temporary menopause, turns off the ovaries and turns off any estrogen-dependent process like endo. And the way that that's a diagnostic test is if you have terrible period or pain between your periods, you take the Zoladex and your pain completely goes away. That's more suggestive that it might be endometriosis causing that pain between your periods, because the Zoladex should turn down or down-regulate any endometriosis-related pain. On the flip side to that is if you have pain between your periods, you take Zoladex and you have ongoing horrendous pain, then I would be erring away from doing keyhole surgery because I'm less likely to think that it's endo causing the pain. Yeah. I would be referring to my phone of friends, my pain specialist, my pelvic floor physio, my amazing endometriosis nurse in-house at the Epworth, Nikki, I'll pay you later, because I think it's less likely to be endo and I think there's less to be gained from doing keyhole surgery. So that's a bit of a diagnostic test with the Zoladex, which is the brand name that I do sometimes for patients who have that pain between periods.
Laura's raised a good red flag. It could be prolapse.
Yes, well, that's a whole nother webinar.
It is. And I think this will be the last question. Someone's talked about how do you go about accessing the pill? Is it mainstream or is it more personalised to fit the individual? Do you want to speak to that, Laura? Because you might sort of be like in terms of if someone's going to start the combined pill, how do you choose? Because how many do we have? 30 something on the market.
Yeah. So cost is a big factor. Levlin, for example, is the most commonly prescribed combined oral contraceptive pill, and yeah, that's on the PBS, so that's often a good choice. But my main thing that I'm really cautious about is, at the end of the day, no oral contraceptive pill is completely mood neutral. So if people are already having a lot of mental health issues, then often I would recommend Azole, the first one to try, because that's known to be the most mood neutral of the oral contraceptive pills. But yeah, in general, there's a huge array, and I don't really know if we need that much choice. So don't be too overwhelmed.
I think the common thing I see is people who've gone on the pill in their teenage years, they've had terrible mood side effects and they're off the pill for life because they're so put off by what happened. And I think as a word of encouragement, hormones change over time, lifestyle, other external factors that we can't account for do change. And if you come back to something again, you might not necessarily have the same experience you had the first time around. And so keep an open mind. They're not all one and the same. Don't strip them with the same brush because we have so many to keep trying. We've got different families. We've got different things that work on particular, like you mentioned, PMDD, PMS. We know things have got better affinities for that. So that's why having a really thorough chat with your GP about all of the symptoms can help guide them in that decision. I think we might have to leave it there because we've gone well over time. My contact details are here, so you know how to find me, so we can talk about all this in depth. I think it's very obvious I could talk about this day and night, and I will never get sick of hearing your story, so please reach out. I'm happy to send resources and everything. You will receive a copy of the recording. And last but not least, thank you so much to our presenters. It's been so lovely to have you. We've actually got them both here in person with us tonight, which is such a treat. Apologies for the IT issues, but we got there in the end. And thank you both for sharing your knowledge with us and being so generous with your time. And I really hope people have gotten a lot from it. I think from the questions that people have been really tuned in. So thank you both, and stay tuned to the newsletter to hear details about the next webinar when that's all organised. Have a
Thanks
great
very much,
evening.
Nikki.
Thank you. Bye.
Bye.